clarifications? Ms. Alex Young.
Thank you, Chairman. My clarification is for the Senior Minister of State, Dr. Amy Khor. Hope she can address my cut on reviewing the medical evidence on preterm viability.
Thank the member for reminding me about his cut. My apologies. In response to the cut, the current cut-off of 24 gestational weeks for abortion was based on scientific evidence of fetal viability outside the womb. According to local experts, as well as based on our hospital's experience, fetal viability below 24 weeks remain low. Furthermore, morbidities such as neurodevelopmental disabilities are very high among the premature babies who survived. International studies and professional bodies also largely support the low fetal viability below 24 gestational weeks. And in addition, in 2018, it's worthwhile to note that about 1% of all abortions performed were performed between 22 and 24 gestational weeks, of which more than half of these abortions were performed due to fetal anomalies and other medical reasons. So essentially, the number of abortions below 24, but between 22 to 24 is already very low, and quite a large percentage is really due to medical reasons. So what we have done really is also to work together with MSF to strengthen pre-abortion counseling and to raise awareness among these women with unplanned pregnancies of the options available to them, including, of course, adoptions. And MOH will continue to monitor and review this issue as new evidence emerge.
Dr. Chashilu.
Thank you. Just two clarifications. I think one is concerning the Agency for Care Effectiveness. I've always been very supportive of it because it gives guidelines on what's the best practices. So perhaps I was hoping the Ministry of Health could share with the House the achievements of ACE thus far. The second clarification is regarding MediShield Life. I think earlier this year there were some concerns about inadequate payouts for certain patients. And I understand from previous replies that the MediShield Life Review Committee is looking at claims limits. But in the meanwhile, to give better assurances to Singaporeans, is there any mechanism by which we can appeal for higher payouts for MediShield Life in certain of these bills? Thank you.
Mr. Chairman, I'd like to thank Dr. Chashilu for the supplementary questions with regards to ACE. Just to give a brief background, ACE, which is the Agency for Care Effectiveness, was actually set up within MOH in August 2015 as the National Health Technology Assessment Agency against this backdrop of rising healthcare costs and the need to drive clinically effective and cost-effective healthcare. And over the years, there has been a lot of good work done by ACE. Just to name some of the achievements that ACE has done, which includes producing technology guidances on drugs and medical technologies. In fact, they have published almost 33 drug guidances, 3 medical technology guidances as of 2nd January 2019. In addition to that, ACE also produces appropriate care guides, or ACGs, which are targeted and concise sets of recommended care practices and pathways that promote appropriate prescribing behaviors. And as of 2nd January this year, they have already produced 9 ACGs. And of course, ACE also conducts value-based pricing, or what we call VBP, in parallel with drug and medical technologies evaluation. And this is to ensure that the price of patented drugs or medical technologies recommended for subsidy commensurates with the drugs or medical technologies value in Singapore's context. So suffice to say, I think ACE has done a lot of good work, and it has also achieved its objective of driving healthcare costs down.
Joan Pereira.
Thank you, Chairman.
Oh, sorry. Ms. Edwin.
I was going to address Dr. Cha's second question. At this point in time, we don't
look at appeals for MediShield life payouts. And the reason for that, obviously, is the more you get a payout on an individual, that compromises the fund because you draw from other persons who have put premiums inside. But on Dr. Chia's point, we can consider appeals for higher Medisave withdrawals, or if not, then the use of Medifund in the meantime. But the MediShield claims limit is being reviewed.
Joan Pereira.
Thank you, Chairman. I have two questions for MOH. First, in my earlier cut, I mentioned that patients now have access to information on bills and fee information in the MOH website, but there is no information in the website on the standard or quality of delivery, basically qualitative information. So would Minister consider providing such information in the website, which I feel will be helpful? First question. My second question. Last year, MOH announced the formation of the Agency for Logistics and Procurement Services, or ALPS for short, to pull together the supply chain functions and resources of the 3 health clusters. May I know what is the progress of ALPS and how has that benefited our patients? Thank you.
So on the quality information of our healthcare institutions, we'll take on the suggestion and we'll take a look and see what kind of quality information we can put up to help patients make informed decisions. So it's a useful suggestion. I want to thank the member for that suggestion. Secondly, on the ALPS, ALPS stands for Agency for Logistics and Procurement Services. It's quite a mouthful, but it's an important initiative that we have introduced. And the idea is to bring together the supply chain functions of all our clusters so that we can achieve economies of scale, aggregate demand, and so on. The first step is to better understand the procurement practices of the different clusters and see whether we can harmonize them, and to achieve economies of scale by aggregating the purchases of the various clusters. Then you have a higher leverage with our suppliers, so we can negotiate for better pricing. And secondly, beyond that, we are also looking at whether we can take the next step of standardizing some of the products instead of each one have their own prescribed specific products to their cluster, whether we can find common products that we can further aggregate the demand so that we can optimize the supplies. Then beyond that, the agency is also looking into how we can reorganize our distribution network, our logistic arrangement, our entire supply chain management, so that we are able to optimize resources. Say, for example, if you can imagine that you store your pharmaceuticals in one warehouse and deliver to another hospital, and you have another warehouse deliver to the other hospital, actually you can just have one warehouse and deliver to both hospitals. So there's opportunity for us to optimize. And lastly, having done some of these optimization, we also want the agency to think out of the box to see whether they can have innovative new ways of managing the supply chain. For example, you can imagine, if you allow your imagine to run wild a little bit, you can think about whether we can deliver drugs, medication to the patients rather than having to collect it from the pharmacy. So if you do a national kind of distribution network, that may be possible. Today, many of us purchase through e-commerce and they deliver to your house quite regularly. But of course, delivering medication is quite different from delivering your food items and sundries and so on. So it is more stringent and we have to study very carefully. But by aggregating the supply chain and logistic function will allow us to think out of the box and develop new models of distribution, which will in the long term benefit our patients.
Sylvia Lim.
Thank you, Chairman. I don't recall hearing a response to my cut on the private ambulance service industry. So may I have a response to that, and in particular, what the ministry is doing to improve outcomes for consumers?
The HACSA, the Healthcare Services Bill, I talked about, will regulate private ambulances. And I think Ms. Lim in particular spoke about the publication of rates for more transparency. So that legislation will mandate the publication of common fees charged, as well as give more transparency as to the bill components to be paid by the consumers, so they'll know upfront what those costs would be. The further details will be set out in the Haksa bill as we put it out shortly.
Ms. Irene Kwee.
Mr. Chairman, can I ask Minister for his comment regarding the proposal in my budget debate speech to acknowledge allied health professional and pharmacists' expertise in the national subsidy framework for cost containment as well as to keep patients in the community, such as extension of drug subsidy scheme to community pharmacists as well as extension of CHARS scheme to allied health services in the community, because we need a holistic approach to keep patients in the community. Thank you.
Thank you to Member Irene Key for the good suggestions. MOH is actually currently studying the models of care that will help patients access allied health services earlier. So, for example, the direct referral to community physiotherapists for agreed musculoskeletal presentations. And on the point about remuneration for the public sector allied health professionals, the point that was raised by Ms. Key, beyond salaries, MOH works with clusters to enhance the value proposition of AHP career in the public sector, and these are things that I mentioned by providing learning and development opportunities. And I mentioned in my speech also about the skills framework for healthcare that was launched in 2019 that will cover various training opportunities and career plans that they can have. As for pay, it's something that we will review, and we always want to make sure that it is competitive so that we can retain good AHPs and in the public sector. Thank you.
Mr. Pritam Singh.
Thank you, Chairman. My question is directed at Senior Minister of State Edwin Tong. This is with respect to my cut on greater Medisave flexibility for senior citizens, particularly those above 60. SMS mentioned in his reply that 8 out of 10 patients pay less than $100 in cash as a result of their hospitalization. Can I just have a sense of the average amount that patients pay for the remaining 20% of that category? And in addition to that, what are the absolute numbers of hospitalizations we're talking about in that particular category, those who pay above $100?
I don't have those numbers to hand now, but if you file a PQ, I'll have those numbers to hand.
Dr. Lily New.
Thank you, Mr. Chairman. 2 clarifications, please. May I ask whether there's sufficient aged care capacity to support our aging population? And secondly, what is HPB doing to make healthier food options more affordable? Thank you.
We have actually since 2015 been significantly increasing aged care capacity in terms of nursing homes as well as community care home and center-based care facilities. In fact, we have added 2,700 daycare places since 2015 so that seniors can access daycare services near their homes. We've also added another 2,300 home care places over the same period. And in fact, the supply of home and daycare places have actually stabilized. We see sufficient capacity at the national level. So in fact, at the national level, there are more vacancies than wait-listed seniors, except that there could be imbalance in demand and supply within certain local areas because of patients of family preferences and so on. So in those areas where there's imbalance, we are actually ramping up capacity in terms of new centers, ramping up capacity as well as building new centers. So our focus now really is on the quality and variety of aged care services available. So earlier on in my speech, I said that we are actually looking at integration of social and health services, better integration, and therefore, because the senior activity centers have now come under MOH, together with the senior care centers, we are now looking at a range of services that all these senior centers can offer within the community, and therefore increasing access and availability of services for the seniors.
Mr. Leon Pereira.
Sorry.
Thank you, sir. Just a quick clarification.
Sorry. Ms. Amri Amin.
To answer the member's question on making healthier food more affordable, This is something that we are studying in greater depth under the Healthy SG Task Force, but there's been some efforts going on. HPB collaborates, for instance, with the local retailers to offer price discounts for healthier choice symbol house brand products, and we've been working closely with retailers such as NTUC, Cold Storage and Sheng Siong. So we will see what else we can do on this front, but it's also worth pointing out that healthier food, that it doesn't cost so much to eat healthy. You can actually prepare the chicken in healthier ways. Thank you.
Mr. Pereira.
Thank you. So just a quick clarification. I thank the Minister for addressing my cut on value-based healthcare. Is there a targeted time frame for moving, in a more broad-based way towards the value-based healthcare model in Singapore? And will a roadmap be published towards that end? Thank you.
Sir, the value-driven care initiative started in 2017. As I explained in my speech, we appointed a National Value-Based Healthcare Work Group, and this work group already comprised representatives from the various public healthcare institutions, so it's already quite broad-based. And to date, we have initiated a total of 17 conditions under VDC, and we want to expand this over time, but we need to do it very carefully because we need, as you pointed out, we need a buy-in from both the service providers as well as patients so that they are on this journey of value-driven care. So I think we will continue to press on with this effort, but it's already broad-based, involving most of our public healthcare institutions, and they have a work plan to gradually expand these conditions to more conditions. But we will prefer to focus on these 17 for the time being, make sure that they are done well so that the same methodology, the same model can then be replicated. So if we rush into it, I think we may create more problems and difficulties. So we prefer to focus on these 17, do it well, and develop a dashboard so that we can get everybody on board and try to improve and optimize the care outcome and cost effectiveness. And then later on, then we can replicate to other conditions.
Dr. Chia, would you like to withdraw your amendment?
Chairman, as always, I would like to thank all members for the active participation and for the very healthy debate. Of course, to Minister Gan, SMSs Amy Khor, Lam Pin Min and Edwin Tong, and SPS Amrin Amin and all staff of the Ministry of Health for the care they have given with their explanations and the surgical precision of their responses. May we all live long and prosper, and with that I beg leave to withdraw my amendment.
Supposed to do it this way. Is the honourable member given leave to withdraw the amendment? I think leave of the majority is given. The amendment is withdrawn. The question is that the sum of $10,023,750,700 for head O stand part of the main estimates. As many as are of the opinion say aye. To the contrary say no. I think the ayes have it. The ayes have it. The question is that the sum of $1,698,806,800 for head O stand part of the development estimates. As many as are of the opinion say aye. To the contrary say no. I think the ayes have it. The ayes have it.